Dr. Prafulla here with Elite Med's another episode of Gloves Off. And today we are honored to have with us Dr. Rashin Padmanabhan, who is a well-known IR in Kerala, who has established the IR department in Kottayam Medical College and who is known to be the mentor of so many IRs in Kerala. That is what I can say. Anybody that I ask about you, everyone talks about, like, he's the one who has mentored. He's the one who has.
So that is how I was trained in my time in CMC a lot. CMC has this attitude of trying to spread knowledge with whoever you have, whoever you comes under your. So I got it from CMC, so I try to do the same with whoever I meet. That's all.
Nice. So I have seen your Kottayam Medical College IR department, and I was so fascinated seeing such a department setup that you have established over there in a government setup. I mean, hats off, but how did you make it happen? Like, what made you think, something like that should be?
Should I tell that story in a smaller way? So I was offered a job in a private hospital. When I finished my stint in CMC, which is in 2021, I was offered a job in a private hospital in Thrissur. So I was planning to go join there. So all papers were ready and my wife's house is in Trivandrum. So I came to Trivandrum and I took a car and I was driving to Thrissur. On the way, my friend is there in Kottayam. So when I got to Kottayam, he said, like, why don't you come and have a coffee? It was very casual. So there's an Indian coffee house there in the Kottayam Medical College. So ഞങ്ങൾ അവിടെ പോയിട്ട് Indian coffee house ചായ കുടിച്ചുകൊണ്ടിരിക്കുകയായിരുന്നു. Then he said, like, why don't you meet my HOD just casually? So I went and met Dr. Sajita. Dr. Sajita is a HOD. Then she told me something very interesting, that they have invested, the government of Kerala has invested in a cath lab set up there, and they are looking out for people to join interventional radiology. At that point of time, I was not that convinced as such, but then when I saw the department, which was under construction at that point of time, there was a ward attached to the department of radiology with that OPD, which is like very unique. Not many medical colleges in India can boast of having a ward attached to the cath lab along with. So that time I was very impressed. And after that, what happened was I was asked to go and meet the superintendent of the hospital. His name is Dr. Jayakumar. If you ask her, very inspirational person. So when I went and met him, he told me something. He told me that everybody in the country, be it poor or rich, should be able to get the same facility despite being poor, or അവരുടെ financial status നോക്കാണ്ട്. So that was really a message that was very interesting. Honestly, that inspired. And then that also resonated with my teaching in CMC. CMC is also a bit like that. CMC does a lot of work for the poorer society, poorer population of society. So I thought, like, this matched my interest. And actually on the way to joining some other place, I came here. Then I drove to that place and I told them, like, I don't think I'll be able to join you. And then came back and joined Kottayam. So that's how I joined Kottayam. In Kottayam, I got a lot of support from Kottayam Medical College and the staff and everybody. So that's how Kottayam developed. It's a good interventional radiology department.
It is. I mean, I remember that day after seeing the department, I came back to Bangalore and to my mentor, Dr. MC Uttappa. I was like, sir, you have to see the department there. I mean, you will not believe that it exists inside a government setup. It's inside a government medical college. And it's not like, I mean, I've seen interventional radiology setups in plenty of private hospitals too. But this is like, you have a dedicated cath lab over there, and right next to that, you have the ward right there.
Correct.
That is what is needed, right?
So interventional radiology is an evolving subject as such. So it's in that phase where radiology, which was predominantly a service department, which actually does not require a ward primarily, as a super specialty called interventional radiology now. So the hospital administration as such in many hospitals fail to understand that it's a very clinical subject which needs admission, which has its own patients admitted, its own discharges. So that luckily for me, our Kottayam, that the superintendent and the HOD understood that very early, and they had actually planned for it. It's not only enough that they have that understanding, they also have to implement those things. So actually Kottayam implemented that. So that is how I was so impressed with Kottayam, and they allowed me to take care of my work, in the sense they did not interfere in any of the decisions which I wanted to implement, and I tried my best to do that. And the same with Believers, where I've joined recently. It is about 1 month back I've joined Believers and Kottayam Medical. They allowed me to work in both the places. So in Believers also is the same CMC culture. That's the thing that attracted me to Believers a lot.
Understood. And being a neuro interventional radiologist, it's like your hands on the vein all the time, 24 hours, right? It's like you should be available all the time. Correct. And in between all this, like, already your workload is so much. And in between this, you have taken out time to establish department, and you are doing the teaching like, the curriculum model for the radiology residents out there. And also you have interventional radiology, post interventional radiologists who are getting trained under it. How do you do everything? I mean, it is so.
No, actually, the answer lies in the question which you have asked. So, if you look practically, I cannot be available 24/7 in a hospital. Okay, it is not possible humanly to be available 24/7. And if you look at neuro intervention, which also attends to stroke, you have to be available 24/7. So the only answer to that, even not only for my hospital but society as such, is to develop more and more neurointerventional radiologists who are capable of doing stroke. So what I have done in my setup is I am trying to train more and more people so that they can also be available for the times when I cannot be there. So when I train 3 people, most of the times they are capable of doing at least starting of the procedure and getting to a point when I can take my time to reach the hospital. So I don't need to be available 24/7 in the hospital. So they start off and they do stuff, and most of the times they themselves can handle the situation. So in case they are not able to handle the situation, then that's the only time I need to come. So my training is basically to increase the number of interventional radiologists all across the state, and if possible wherever I can touch. When and there's a human limitation to my this thing. So I train around 3 people per year, and every year add three more people and try to give them full exposure, being and staying with them, so that these interventions are available for everybody. So when the demand decreases, as in the demand of doctors decreases, it gets cheaper for the patients. Because like when you are a unique person, you need to pay a lot to get that service. So when you have more and more intervention radiologists, you realize that stroke services become cheaper, other interventions become cheaper, and it's available for everybody in the society. That is those, like I tend to plan, I think.
Yeah, so we were talking about stroke management. Yes, that's something I kind of feel like it's a need of time. I mean, I come from a very rural place called Kannur. So in my town, I understand the value of the stroke management, and also me previously working in neurosurgery department. I understand, like, how much it is a person who is capable enough to do the intervention for the stroke cases are needed in the rural setup. Correct. And also right now with the treatment, when we are approaching the hospitals, we also are facing the same difficulty. Like one who are trained to do the neuro interventions are very is less compared to the larger there's radiology crowd, right?
That's true. Actually, neurointervention is a little more niche. It's kind of it's a part of general intervention. It takes a little bit more of a stress, and all interventions are very stressful. But neurointervention has its own complications and its own set of challenges. So not all intervention radiologists do neurointervention. So that way, intervention radiologists itself is the less of a headache. Often, the people doing neurointervention are even less. So that is something which we are trying to, as a society and as a group of radiologists, that's something which we are trying to promote. Like get more and more interventional radiologists to be neurointervention. Stroke is, the intervention radiologists, they are talented. They just need some motivation to go and do neurointervention like stroke, because more people are there, more lives you can save.
Yes.
Yeah, because whenever you reach a hospital, if that hospital is capable of doing stroke interventions, it will be good for the patient.
shifting. Yes. In case of this acute stroke, right now, I mean, I always used to feel the same thing. Like, whenever we sit at a casualty, I was working in casualty previously, post-casualty phase. So, whenever I sit at a small hospital, I get a question from the patient side, like, do you do angio here? When they have a chest pain, do you do angio here? If angio is not available, and if the patient is convinced, only we can start a medical management. Otherwise, we are supposed to shift the patient to the center where they are doing an angio. I feel like, I mean, we all know, and awareness among people regarding stroke is very less. They don't know still that in the case of acute stroke, majority of acute stroke can be managed and the patient can get full recovery post intervention procedure.
Yeah.
Right?
There are two reasons for that. There's a very, I mean, I've always thought about this. Two reasons, maybe not comprehensive, but two reasons which I thought one was very interesting. One is that the stroke intervention as such is not very old. In the sense, it's only in 2015, which is less than 10 years back, that RCTs have proven that it is a model, it is a treatment of choice. So before 2015, there is no mechanical thrombectomy which you can advise the patient. So in 9 years, 9 to 10 years, I tell you that you can offer mechanical thrombectomy to the patient. Though before that, they were trying something. Data proven only 2014. So it's only that old. People are just starting to know. And second thing is very interesting. What I found was that most movies or most dramas or whatever it is, if there is a emergency, they want to show some emergency situation. It will be mostly chest pain and heart attack, and the patient rush to the hospital and ambulance. Very less social thing channels like movies or dramas, and he show stroke and how it can be recovered. Maybe because there was no recovery before. The people don't get to see these things in public. Heart chest pain, and people communicate with you and there are no angiogram, they do stent to do. That's a normal thing to say. But nobody says, oh, stroke went and did mechanical thrombectomy, he is fine. I don't generally get to hear that.
Yeah, even in medical community, awareness of mechanical thrombectomy is very less. I mean, you go to a clinic, a small center for like from place like Kannur. I can say in Bangalore and all, any large hospitals have an interventional radiologist and people who are working over there, they know about thrombectomy. But in a small centers like, a stroke case and all goes to a nearby government hospital or nearby small periphery center, there the casualty doctor, whomever is sitting there, they're supposed to tell them like, പേഷ്യൻറ്റിനെ അത് പറഞ്ഞ് മനസ്സിലാക്കി കൊടുക്കാനുള്ള ഒരു കാര്യം നമ്മൾ നടക്കുന്നില്ല. ഒരു ഫസ്റ്റ് പോയിന്റ് കോണ്ടാക്റ്റിൽ തന്നെ അത് മിസ്സാവുകയാണെന്നാണ് ഞാൻ വിചാരിക്കുന്നത്.
Believers in where I work, very, very open hospital. So we were discussing this, and now we have started one program in Believers. We are seeing the challenges what a peripheral hospital faces, and to be genuine, they face certain challenges. So we are trying to solve those things with him. So one challenge which a hospital has is to get 24/7 radiologists. Okay, they may have a CT scan, but they don't get a report fast enough to see that it is a stroke. The stroke and area. Clinically, it might be stroke, but whether there is a large vessel occlusion, whether that is already infarcted, we don't know those things. So they didn't have 24/7 radiologists because it is difficult to have a 24/7 radiologist. So we are trying to associate with them and report those images immediately after the stroke result, because nowadays that technologically that is possible. And second thing which we are doing is to try and communicate with the neurologist to evaluate the patient and keep our cath lab ready before the patient is being shifted, even from that trying analysis, so that we save time. And none of this has got any financial or liabilities. Like, there's very no cuts, nothing like that. The believers that way is very good in the sense that they are honest in those things. So no financial liability, but otherwise trying to help those patients who are on the periphery to get to a stroke ready center. And it can be any stroke ready center. It might be this hospital itself, but if they had a closer stroke center, let them go there, because time is very, very valuable. Yeah. The more time you take, the greater the damage to nail. So those are the ways in which we are trying to solve this issue where availability is.
Also, we should make it like, to the larger public, we should let them know that something like this exists. I mean, you have to reach hospital. ഇപ്പോൾ ഒരു സ്ട്രോക്കിൻ്റെ സൈന് വരുന്ന സമയത്ത് നമ്മുടെ നാട്ടിലുള്ള ഒട്ടുമിക്ക ആൾക്കാർക്കും അത് മനസ്സിലാക്കാനുള്ള കഴിവ് ഇപ്പോഴുണ്ട്. സ്റ്റോക്ക് വരുന്ന സമയത്ത് മുഖം കൂടുക എന്നുള്ളത്, അല്ലെങ്കിൽ കണ്ണിൻ്റെ വിഷൻ കുറയാന്നൊക്കെ ഉള്ളത്, അവർക്ക് അതൊക്കെ പടത്തിലോ അല്ലെങ്കിൽ പല അവയർനെസ് വീഡിയോസ് കണ്ടിട്ട് അവർക്ക് അതിനെപ്പറ്റി അറിയാം. ഇപ്പോൾ ഒരു ചെസ്റ്റ് പെയിൻ വരുന്ന സമയത്ത് എങ്ങനെയാണ് ആൻസൈന ആണോ അല്ലയോ എന്ന് അറിയുന്നതെന്നുള്ളതിൻ്റെ ഒരു ഡിഫറൻസിയേഷൻ അവർക്കറിയാം. അതൊക്കെ ഇനി അവരിലേക്ക് എത്തേണ്ട കാര്യം, ഇങ്ങനെ ഒരു സിംറ്റം വരുവാണെങ്കിൽ ഇത്ര മണിക്കൂറിനുള്ളിൽ നിങ്ങൾ ഹോസ്പിറ്റലിൽ എത്തുവാണെങ്കിൽ, നിങ്ങൾ ഹോസ്പിറ്റലിൽ എത്തേണ്ടത് നിങ്ങൾ ഏതെങ്കിലും ഹോസ്പിറ്റലിലേക്കല്ല, ഇന്റർവെൻഷണൽ റേഡിയോളജി ഫെസിലിറ്റി അവൈലബിൾ ആയിട്ടുള്ള ഒരു സെന്ററിൽ നിങ്ങൾ ഇത്ര മണിക്കൂറിനുള്ളിൽ നിങ്ങൾക്ക് എത്തിച്ചേരാൻ പറ്റുവാണെങ്കിൽ നിങ്ങൾക്ക് ആ ഒരു ഭാഗം എന്താ പറയുക കംപ്ലീറ്റ് റിക്കവർ ചെയ്യാൻ പറ്റിയെന്നുള്ളത്.
ആക്ച്വലി ഇതിൽ ദേവി ഈ സ്ട്രോക്കിന് ചെസ്റ്റ് പെയിൻ വരുന്ന സമയത്ത് ദേ റിയലി ഹാവ് പെയിൻ. സോ the other thing is stroke വരുന്ന സമയത്ത് they have some weakness on his thing. So I have my personal experience in family and otherwise patients also say അവർ കിടന്ന് ഉറങ്ങാമോ, they'll go and sleep thinking that ഇതൊരു തളർച്ചയാണ്, യു വേക്ക് അപ്പ് ആൻഡ് യു വിൽ ബി ബെറ്റർ എന്നുള്ളൊരു ആറ്റിറ്റ്യൂഡിൽ അവർ ഒരു സൈഡ് വീക്ക്നെസ് ഉണ്ട്, കുറച്ച് ചിലപ്പോൾ ക്ഷീണത്തിൻ്റെ ആയിരിക്കും, ദൈവം സ്ലീവ് ആൻഡ് മേ ബെസ് വേക്ക് അപ്പ് വിത്ത് പ്രൊഫൗണ്ട് ഫുള്ളി എസ്റ്റാബ്ലിഷ്ഡ് സ്ട്രോക്ക്. അപ്പോൾ ഈ ആ ഒരു ഡിഫറൻസിയേഷൻ ആൾക്കാർക്ക് ഇപ്പോൾ ടു ആക്സെപ്റ്റ് ദാറ്റ് യു മേ ബി ഹാവിങ് എ സ്ട്രോക്ക് ഉള്ള കാര്യം. അപ്പോൾ ഐ ഹാവ് സീൻ പേഷ്യൻസ് ഹു റിയലൈസ്ഡ് ഐ ഹാവ് സം വീക്ക്നെസ്, ലെറ്റ് മീ ഗോ സ്ലീപ്പ് ഇറ്റ് ഔട്ട് ആൻഡ് കം ഔട്ട് എന്നുള്ളത്. ദാറ്റ് ഇസ് എ ഡിസാസ്റ്റർസ് തിങ് ടു ഡു. If you have any doubt, it is better to go to the hospital, find out that it's not stroke or anything, just get it ruled out and then come back home. അപ്പോൾ ആ ഒരു വാല്യുബിൾ ടൈം കിട്ടുകയാണെങ്കിൽ there is something called as TIA, അല്ലെങ്കിൽ EOS, transient ischemic attack. It might be very short, 30 seconds to 1 minute of stroke, but that is a big indicator that you can have stroke very soon. ആ TIA എളുപ്പം ഐഡൻറ്റിഫൈ ചെയ്യാൻ പറ്റിക്കഴിഞ്ഞാൽ നമുക്ക് വളരെ significant ആയിട്ട് മെഡിസിൻ സ്റ്റാർട്ട് ചെയ്യാം. കെറോബിറ്റ് സ്റ്റെൻഡിങ് ചെയ്യേണ്ട പേഷ്യൻറ്റിന് കെറോബിറ്റ് സ്റ്റെൻഡിങ് ചെയ്യാം ആൻഡ് യു ക്യാൻ ആക്ച്വലി ഗെറ്റ് ബാക്ക് ടു ലൈഫ് വിത്തൗട്ട് എനി ഡെഫിസിറ്റ്, നോ ഡെഫിസിറ്റ് അറ്റ് ഓൾ. പക്ഷേ ആ ഇതിൽ you catch, then is the more important thing.
I know.
Yeah, awareness is very important and also the attitude has to change.
I mean, in a larger way, I mean, like we see was we have to target a lot of people at a time, right? Like medical officers, personal based doctors, any doctor, you can say, and any small scale hospitals, and also to the larger public. Correct. I know. I mean, it's only like 20 years since that we are doing interventional radiology procedures. 10 years. Interventions are generally tender radiology. And right now, since the larger seats are also coming up, so people are getting aware about it. And I don't know, I still feel the same difference. I mean, what I've seen few years back, then I went to Bangalore and I'm in Kannur, how it is. The same thing. Yeah, we were talking about stroke. Also about aneurysm. I mean, I personally want to talk about aneurysm because I remember in my neurosurgery residency, I've faced cases where, I mean, I know how it is going to affect a family or a patient if you wait for the surgery. So, yeah, I mean, what do you have to talk about?
Yeah, I don't know some managers. Aneurysm is basically, now fortuned vessels. So some way you have to pack it. You can do it surgically. There's no harm in doing surgically. Surgery is definitely an option for some of the aneurysms. But nowadays we have endovascular coiling also, where you can angiographically go and do without any surgical opening. You need to open the skull and the recovery times are much better and outcomes are similar, the same almost. So that is another option we have. Now, yeah, I had about the scenarios which you have told. Yes, we had patients where they had to wait for surgery and for some reason. But endovascularly, you could have done those patients and then, life changes for them actually, because the recovery times are much faster. You don't have to be in the hospital. You can be observed and then you go back without a start. Yes, for some people, it's a big thing because you don't need to shave. And for all those things you don't need to do. Yeah, it's a big thing for them. Right? Aneurysm coiling is a big thing.
Aneurysm എന്ന് പറയുന്നത് ഒരു കടുത്ത തലവേദന, right? That's how we explain it to the patient, no? Like കടുത്ത worst headache of the type. അങ്ങനെ ഒരു കാര്യം വന്ന് അവർ വരുവാണെങ്കിൽ ഫസ്റ്റ് ഓഫ് ഓൾ ഹിയർ ഐ wanted to ask from the viewer's point of view, aneurysm, can we do interventional radiology procedure, coiling, in every aneurysm cases?
Most of them, if not all, I would say most of them. See, I don't remember the last time when I refused an aneurysm because it was not possible. Like all the aneurysms which I remember last, we have been able to coil. Sometimes it is challenging to coil, and at those times we do send them for clipping. And many times it's the other way around. They cannot clip, especially posterior circulation aneurysms. It will be much more challenging to clip. So they send for surgery actually sends more cases to coiling than coiling sending to surgery. It was technically it is probably easier to coil than do surgery for most of the aneurysms, not all, but most of the aneurysms. Yeah, so like we were telling about the symptoms, yeah, it's a worst headache you can have, and not all headaches are obviously subreferent hemorrhage, and some of them are bad headaches. But when you have a ruptured aneurysm, you will really know that you had a headache. Then you have to go to the hospital. When you take a CT scan, plain CT scan itself, you can see in blood. Some of them are, sad that they don't survive. It's a very big disastrous disease to have, because 10% don't even survive. Yeah. They don't get to the hospital. But 90% get to the hospital, and most of them can be recovered if we do early procedure and take good care of them.
While we were talking about stroke and aneurysm, the thought that crossed my mind was, in this very short time in my life, in this past 4 years, I can say, 4 to 5 years, I have witnessed or heard from the people in my close circle or the people that I have known who has lost a person for a stroke or an aneurysm. So it's not a rare thing.
It is not easy.
It's not a rare thing.
Stroke for sure is not.
Yes.
And aneurysm is also not that.
Not a rare.
Actually, some of those patients who pass away in the periphery, we don't even know that they died because of aneurysm. Because either they don't reach the hospital, or the place where they reached, they don't have the facility to do CT scan. And some of them pass away there because it's very critical. വളരെ കുറച്ച് പേഷ്യൻസ് ആണ് who have severe headache and they get the കേരളത്തിൽ maybe it is more because awareness is more, and but I'm sure that in larger states like Madhya Pradesh and Uttar Pradesh, but for patients to get that, it's not that rare. It's not that rare to have aneurysms and rupture. Definitely needs better care. Yeah, you will find relatives who have stroke, and yes, for sure, yes.
You're finding that's what I was thinking. There are a plenty of people that even I myself, me as an individual, like a sample size if I take, there's a large amount of people that I have known. So it's not a rare thing. But even after that, the best management for an aneurysm or a stroke is a rare thing in Kerala right now.
Yeah, it's better than before, but it is definitely not up to So when I go for these public awareness talks, I always ask them, do you know anybody? Because that's how I get their attention. So I ask them, like, do you know anybody who's had a stroke, or do you had an aneurysm? Significant population actually raises their hands. You know that all out of the people sitting there, 20 to 30% to 40% would raise their hands, which is big number. You don't take any disease. 20 to 30% of the persons will raise their hand saying that I know somebody who has had this in my near relation or my in my space. So that's a big number. Yeah, so it needs a lot more awareness for patients to come to the hospital. Where there is facilities available.
And also for the hospital to understand the minimal aneurysm and all, the hospitals which doesn't have an interventional radiologist there or a neurointerventional radiologist there might post the case for a medical management.
Yeah.
Because it is not a surgical management. It's not eligible for a surgical management because it's tiny.
Correct.
So they'll wait. And we have witnessed cases who has lost their life in that waiting period, right?
Yeah, because of that, it's possible. See, that sometimes the surgery becomes a challenge, and it's unethical that way to hold the patient because you're not able. It's okay to not able to operate, but it is not okay to not send them to a center which can do a job, which can do treatment. Just because you cannot clip or for that matter do any procedure, you probably should be gracious enough. I can tell you an example. Like last week, I had a patient with headache. So that patient, when I realized it's not subarachnoid hemorrhage, but that patient required detailed analysis. Okay, and in I thought like my hospital, the neurologist who had seen him, he probably skipped certain evaluation. So I know a good friend who was a better evaluator. So I sent him that patient to him, and he thoroughly evaluated that patient, and he found out the cause to be trigeminal neuralgia, and he started on tablets, and immediately the patient found relief. So he called me and thanked me for sending him to a different service. So I realized that it's important for a doctor to realize that if you cannot handle the situation, it is important for you to send them to a place where you can handle it, and all of them will be thankful. Patient will be thankful, the person who did the surgery will be thankful, and of course you can take satisfaction the fact that you were a part of somebody's survival. Yeah, so that should be done, I guess.
Thankfully, right now, because of you also, I should say, there are more people coming out who are capable enough to do neurointerventional procedures
Yeah,
in Kerala.
that is true. So that is part of my desire. You know, I want to bring in more people who can do neuro intervention, and it should be available every nook and corner. I have a family member in my life who's very close, who I have lost because he could not get mechanical thrombectomy. My wife's father, Malini's father, who had a stroke, and he could not get mechanical thrombectomy. So I understand the pain the family had to go through for a long time, because it's not like we could not afford it. We could have afforded it if that were the case. But he did not have the facility to go and get in. And he was not in Kerala, he was in Bhopal. So he could not get that facility there. So I realize in our state, that's all I can reach for now. So I have to get it in every nook and corner, and to see that you know it's available everywhere. Number of strokes are immense, and how do you know that is when you look at countries like Switzerland and where facilities are available, the population is less. Even then, they have 5 to 6 cases per week in many of the hospitals. So that's the load which you, if you really want in a society. So in a country like India, no number of doctors are enough. Actually, if you really start doing it, we need to do few things like reduce the price of mechanical thrombectomy, which will happen in time when more and more devices are available. Nowadays, the competition is more, so the prices have come down. More number of doctors are there, the prices will come down. The hospital also will bring down the prices that we have. So, the answer to having a better care for stroke is to bring in more neurointerventional radiologists who are capable of doing stroke. So, that is where all this started.
Understood. And that's a great move. I mean, yeah.
It just came naturally. I mean, it's nothing that it just it's just a thought and came naturally. Thing way.
That's a nice move actually. Because I also remember from my residency and all during MBBS or during the residency period, we as a junior doctor when we see cases and that gets stuck inside our heart and brain, I'll say. I mean losing a patient and for an aneurysm or for a stroke. And then later on after 10 years, when I am witnessing interventional radiology procedures and then I'm seeing neurointerventional radiology procedures saving lives, people like, why was it not done at that point? Because for me, as a junior doctor back then, it's that face of the relative that still stays inside the head, right?
Okay.
I mean,
Helpless.
not the helpless one.
Relatives.
Yeah. So that's
So I am lucky in the sense that I'm in a situation where I'm working in Kottayam Medical College as well as believers. So in a bit of both, because the poorer population many times come to Kottayam, and the people who can afford facilities will come to believers. So like I get to help the poorer ones who really can't afford anything, and also the ones who probably want a little bit more service and better facilities, not in terms of the quality of work, but the quality of wards and air conditioning and stuff like that available. So I get to treat both. So I'm in that unique, space. So in this space, I'm able to develop more and more people who do neurointervention.
understood. And so, what about like since you work at a medical college, a government medical college, what do you think your residents or your interns or your medical students do they know about interventional radiology and neuro interventional radiology procedures?
So some of them or most of them don't get exposure during their medical period. Apo, many of them come to or start internship not knowing interventional radiology at this point of time, because our outreach hasn't reached the medicine graduates as such at this point. Actually, the moment they get into internship, many of the departments like surgery in medicine, all of them, they are heavily dependent upon interventional radiology now. At this point of time, in Kottayam and all the other hospitals, surgery people, medicine people, they're all very friendly with interventional radiology, and we are too with them, because the kind of support we can give is, for instance, you do a very complex surgery. Let's say some of the arteries leak post surgery, there is an aneurysm. Now, for them to open up and go and treat that is very, very difficult. For us, it's just a 5 minute job to go through the vessel and then block off that. So, surgery is very friendly with us, and we are with them too, because we get the opportunity to help those people. That's it. That's very gratifying. So, when the interns are posted in those departments, they get to see what we can do for them. So that way, the moment the interns come to their parent departments like medicine, surgery, they understand what interventional radiology is. And nowadays, they have also started posting interns in interventional radiology. So they spend time with us, and maybe they won't be able to do the procedures as such, but they get to see, so that when they become other doctors, like when they become medicine super specialists or surgery super specialists, they know, okay, these are the options available for the doctors. So in future, I'm sure they will be aware of this. I was not aware when I was doing radiology. So nowadays, interns also know what is to have a interventional radiology. Yeah. So we are creating awareness.
I mean, in that way, Kottayam Medical College is actually doing a great job. I can say this. You are doing your best. Okay, sir. So, outside all this, outside the cath lab, how do you? I mean, you are working at Kottayam Medical College. You are working at Believers. You are doing all these things. Do you get time for family? And I should ask Cookie about this a lot.
No, so yes,
Cookie has
my daughter,
beautiful,
6-year-old daughter.
yeah, cute one.
Yeah, so uh, that work life balance is something which I struggle a bit with, but I try my best to balance it out. So, one of the, and like I told you, another reason to train more people is because everybody can have work life balance. So, the more the number of people, everybody gets time to spend with their family, and so that they are happier serving the population that they are serving. If there's somebody who's always intensely doing only work, there'll be a lot of anger towards the patients, I think. So if you give them breaks, time in between, so they work happily, they stay happy. So we are trying to increase the number of people, even in my department. I know my juniors are currently overworked, and they're very sweet. There are moments of anger and things that happen because they were also really over. But we are getting more people, and that way work life balance we're trying to get there. Yeah, but sometimes when there is an emergency, you don't think about family, to just go and do those things. Family understands. That's the best thing. My wife is a doctor, and she understands for sure. And somehow Cookie also understands. That's very sweet. So when I tell her I'm going to hospital for an emergency, she generally doesn't cry. So that's very sweet.
Yeah, she's such a cute kid. I mean, today I'm sure she must be cursing me that I took out the Sunday.
I told her I'm going to the hospital for an emergency. I lied to her. But yeah, she's 6-year-old, so she'll understand. Nice. Yeah.
So, do you do any other hobbies outside your cath lab? Do you get time to do all that?
No, no, nothing that I am proud of. But I'm changing certain things in life. In the sense, I'm getting my family to move to Tiruvalla. We are staying in Cochin now. So we are moving to Tiruvalla because I want to be in between medical college and Believers. So once that will happen in a month's time or so. So once that happens, and traveling will be less. I want.
ചിലപ്പോ പടങ്ങളൊക്കെ കാണാറുണ്ടോ? Like, do you get to I mean, I know that I should not ask all these questions. Listening to you that you have so much of work to do. I just wanted to know, like, how you spend your me time otherwise.
Movies are something which we regularly watch. So Mali and I, that's our me time.
Okay.
Cookie sleeps at 9 o'clock. So we book a movie after 9 o'clock. So 9:30 or 10, we put her to sleep, and then we make time to go out and watch movies. So that's something we regularly do. That's our me time. That we regularly do. But otherwise, other hobbies like I used to sing at one point of time. So I want to get back to once upon a time. So those things I might get.
We should do a podcast on that.
Oh, I don't do it now anymore. Once upon a time I used to. So I really want to get back to all that. I mean, whenever time permits. Okay.
Nice.
I love music. Music, though I love.
Okay. But you and ma'am has that very welcoming a thing for anybody who is coming in. Well, I mean, like I felt that day, like I met her for the first time in that day when I met her, and she was behaving like a sister. I mean, I got that sisterly feel from her actually.
Part of that is my our mentorship in CMC. CMC is that way a very nice space to be. It's a family kind of place. You learn those things in CMC. CMC you can walk into a professor's house. So all of us stay together. The professor, associates, juniors, everybody is in the same campus. So you go for a morning walk, your professor will be in your shorts and walking around. So you don't have that sort of feudal attitude there. Everybody is friends and everybody. It's a short life. What's fun if you are secure and secluded and do that.
I know that is.
Yeah.
I'm so grateful that I have met people like you in my life that I am being mentored. I can say.
You too, professionally. You're a young entrepreneur, so like you started a coffee shop, and I see your videos. I actually tell people that I know somebody is so young who started so many things together. And you're somebody who I'm inspired. So thank you so much for this.
Thank you so much, sir. Thank you so much for spending your time. That too, your very Sunday time with us for Release Made. I'm really thankful.
Thank you, Professor. Thank you so much. Thank you.